admissions into specific UW schools. DPI is opening a waiver application process for certain provisions of the UW Guaranteed Admissions Program, specifically 2023 Act 95. The waiver will help districts address complexities due to discrepancies in the law and local policy. DPI will consider school board requests to waive requirements listed in Wisconsin statute 118.58, section 2, specifically the provision that students are ranked based on academic achievement. DPI aims to provide flexibility in how districts rank top 5 and 10% of students to submit to UW system under the Guaranteed Admissions Program. Welcome new teachers. On last week, on August 21st, we welcomed new teachers to the West Allis, West Milwaukee School District. We are thankful that they are part of our community and looking forward to an exciting school year. I want to thank those board members who came to the event, as well as all of the administrators who attended the new teacher welcoming ceremony. Battle of the Dogs. Congratulations to our Huskies and Bulldogs as they faced one another Friday night under the lights in the annual Battle of the Dogs. Students, families, staff, and community members enjoyed a tailgate followed by the game. Fun was had by all. So again, congratulations to the young men who were out there playing. Congratulations specifically to the Hale Huskies for their victory on Friday night. Thank you to everyone who made opening day possible. On today, we celebrated and welcomed back all of our teachers to Nathan Hill as for our welcome back and opening day ceremonies. When I tell you the atmosphere was electric, I am not exaggerating. I probably was the dull one in the room. They were very excited and just enthused and hey, the energy was at a high. I want to thank Dr. Anthony Muhammad for being our keynote speaker. His address definitely aligned with our targeted supports that we're undergoing for school improvement. And so we are definitely grateful for his participation. And again, thank you to all of the teachers, our administrators, our principals actually had a dance off during the welcome back and opening day ceremonies. And they were not aware of the dance off. We called them on the stage and put them on the spot. And when I tell you they were truly some troopers. They were great. I have to give it up. Special shout out. We had a four-way tie for the winner. And at the fourth name, we had Erica Minsloff from Horseman, Matt Lesser from Nathan Hale, Steve Harris from Franklin. I'm missing the fourth person.
Brian.
Brian, yes, yeah. Brian was the fourth, so Central and Hill tie. So it was great just to see them come out of their shell and just really just enjoy the moment. I'm glad they didn't ask me to come up there because they would have been disappointed. Some of us have the rhythm and some don't. And I'm one of those guys. So I'm not afraid to say that. Some of the community visits and meetings, West Valley Rotary Club, cabinet one-on-one meetings, meeting with past board member. I want to send a special shout out to Evan Schwartz and his family for inviting my family and I to dinner on last Wednesday. Evan and I have had a couple of opportunities to have coffee. And so when he invited my family and I out to dinner, I gladly accepted. And so anybody else who wants to have us out, just an invite is needed. Give me a little notice. I can tell my wife. All right. West Milwaukee Night Out. I participated in that, the 90th anniversary of the Recreation and Community Service Department. We held a documentation guidance training for all district administrators. It was led by our attorneys. New teacher welcome back. I just mentioned that. I want to also send a special shout out to the RAD group. Group communication board ribbon cutting ceremony. Thanks to Ms. Jane Carr for participating in that event as well. Battle of Dogs, mentioned that already. Opening day ceremony, and today cuts for kids. I have a fresh haircut. I participated as well. And when I tell you the line was long and we had a lot of barbers come and volunteer. So it was an excellent event. Special shout out to Bobby as well as to Shelly and then the entire rec staff for putting that particular event on. Just wanted to kind of go through today. As of today, our vacancy report is at 1.47%. So compared to last year, this time was at a little bit over 5%. So that's a reduction of about 3.7 percentage points. So we're definitely almost there. I can tell you the vacancy is on one hand, so we're in a good place. Wednesday, back to school bash. Thanks, Mr. Lee, for putting us on the spot. Since you made that announcement last year, it's now an annual event, so we want to definitely live up to your expectations. So we're inviting everyone to please come out to this event and support. On tonight, we do have a special recognition and community partner who wants to make a special presentation, I should say. I have Mr. Jerry Falk and Mr. Bill Barris who are here. They are, Mr. Bill Barris is the Grand Knight of the Knights of Columbus. And Jerry Falk, I have to give him his props. Jerry is a true homer. He is the #1 Brewers fan, and he and I go back and forth at Rotary about whose baseball team is better. And so he and I are what I would say are good buddies. I see Mr. Jerry out at our events, and he is a huge supporter of the theater program, as well as shared journeys. And so I want to allow them to come up. And this presentation will be in honor and memory of Jerry Fetzer, widow Donna, and daughters Jill and Kelly will be in attendance, but not speaking. There's a $7,500 check. You want to come on up and make this presentation to share journeys? I know you like to talk, Mr. Jerry. I took a lot of your script.
Thank you, Dr. Robinson. Very well. I am very pleased to be here to represent the Knights of Columbus. We started in 1947, our council. Some of you might have been to our old clubhouse up on 92nd Street. In fact, I know West Dallas Central and Nathan Hill held some of their parties up there over the years. And when we were in need of some entertainment and whatever, I'd either call the Strolling Strings from West Dallas Central or somebody like that. And we always did a great job. But yes, the Jerry Fetzer. Jerry Fetzer was our financial secretary of the council for many, many years. And his daughter Jill, in particular, is a speech therapist and has worked with some of the schools in West Dallas. And once we sold our building, we did some smart investments, and we have a little more money now than we did in the past. We have, of course, as Dr. Robinson mentioned, we have a charity foundation that we've had in existence for about 15 or 20 years. So Shared Journeys has been one of our annual people up that we take care of. In particular, when they moved over to the building of the Presbyterian Church, they needed some major renovations. There were some certain code violations that would have been in existence. So at the time, there was a shortage of budget. So we did donate the $40,000 to that project that time to get it finished. And I'm happy to say we continue to support the Shared Journeys, but that's how we started. The other thing is the marquee over there at Central High School. That was an old marquee. They had to go out and change the letters and put the message on it. And Dave Owens, who I worked with through the Rotary, said, "What are you going to do with that old marquee that you have on 92nd?" Well, we said it's probably going to go with the bricks, to a dump site. Well, no. So we spent $20,000, had it redone, got the bulldog on there, and now they could set the message up on a pneumatic board. So we're happy to do that. So I'm going to let my cousin and our Grand Knight, Bill Barris, say just a short welcome, and then I'll get on with the presentation.
Thanks, Jerry. And thank you all for having us here tonight. It's It's special. Like Jerry said, the KCs have been here in West Dallas for a long, long time, over 75 years. And we love the city. I grew up here. My dad retired as fire chief here. Brother retired as a firefighter, brother-in-law retired as a police officer. And probably most important, my grandfather is Al Holer, was a member of the school board back in the day, and then a longtime alderman when the hospital was built and Greenfield Park was annexed. So it's a really nice history, and it's a joy really to be here and for us as a council to help everyone out. So again, just wanted to say thanks. Jerry has a number of things to go through. We actually have two things, Dr. Robinson, to provide. So he's got, well, maybe in one other surprise as well. But just thank you again, and thank you for all that you do, because education is number one for sure. So thanks for all that you guys do.
Well, okay, getting back to Jerry Fetzer, he normally in the past, he's the one who writes all the checks and took care of our finances for many years. So it was in early May that he told me that his daughter Jill knew that we were going to be giving away some rather substantial amount of money, and that there was a need for the West Dallas School District to get some help. One of them was for maybe what's known as deferred maintenance, and another one was we came to find out that there's what is called a closed closet at Horace Mann Elementary School. So Jerry said he would like to have something done about that. And before he was able to do it, he unfortunately was diagnosed with brain cancer and passed away about a month ago and whatever. So that's why his family is here, his wife Donna and the two daughters and whatever. So anyhow, we thought it over, and we thought the Knights of Columbus are big on what's called Coats for Kids. This is a nationwide program. And so we thought, well, okay, we helped one of the elementary schools on the far west end, a Catholic grade school last year. We donated 152 jackets. These are heavyweight winter jackets, and they come in both boys and girls style. So I really owe a lot to Sarah Shepard, who set me up with, she's the one, Dr. Robinson, that invited me here. So if I talk too long, you can blame her. But anyhow, I told her about the Coats for Kids things, and I said, well, I don't know, we could donate 100 or maybe 200 or whatever. But then again, would there be one child that wouldn't get one? So she got in contact with the principal down there at Horace Mann and found out that the need was for 420 jackets. Well, that is what we're donating.
Wow.
They are going to be available. They're supposedly being shipped tomorrow. So Sarah is going to help me out on that and get a couple of vans, and we'll get them down there and whatever. These are heavyweight jackets. The principal, I worked with a few other people, and he decided how many, and they come in both girls and boys style and whatever. So we got it exactly what she wanted and whatever. So I'm going to feel good knowing that there's 420 kids running around with a heavyweight jacket. Today they wouldn't need them, but and then the other thing is I'm going to present the check to Dr. Robinson. This is for the deferred maintenance and whatever. So it's for $7,500. That might fix a couple bubblers or something like that. But anyhow, this is it. And whatever, and thank you. And I do have one other special donation, presentation, and I'm going to have to go and get it. And now, the doctor brought this up, and yes, he is in the Rotary Club along with me. And I enjoyed the very first time the very first meeting he showed up. He's wearing what other than an orange shirt, and he says, hey, I'm from Texas, and the Houston Astros is my team. And he says, you know, well, how many World Series have your team been in? And I said, well, we're in one and we didn't win it, and whatever. So we sort of jaw about baseball. But you know, it made me sad to think that there's a possibility that Dr. Robinson, if he would go to a Brewer game, that he would not have an official Brewer hat. Whatever, but Bill, did I miss something? Why don't you?
It says World
Okay.
Champs 24. On there, right?
There we go. But thank you all for what you do, especially the shared journeys. That is dear to our heart too, as Knights of Columbus. Lisa Cola and the people that run it, I mean, thank you for that. You were unique in getting something like that going. You should all pat yourself on the back for the support you've given and whatever. They are on our annual list. Dr. Robinson, if we got any bucks left over next year and you still need some maintenance, we probably will be able to take care of you, okay? But thank you all.
Yeah, thank you guys so much.
Thank you. Hi, Erica, nice to meet you. I like her shoes. Oh.
Save this picture here.
Yeah, this picture is good.
1, 2, 3. Take a look at that. 1, 2, 3. Great.
One other thing I want to compliment Dr. Robinson. Like I told you, we're both Rotarians, so West Dallas Rotary. We meet on Thursdays. I'm the one that picks up the visiting students from both Nathan Hale and West Dallas Central. We have them come to our meetings and whatever. Dr. Robinson comes over every time he's there and greets the students, sits down with them and whatever. I mean, he's unique. And I mean, where else can they sit with the superintendent of their schools, you know, and have a lunch? Thanks.
I didn't pay him to say that.
Thank you. Thank you. Yes.
Thank you, Jerry and Bill for the donation. I also want to thank the Fetzer family as well for considering the West Dallas, West Milwaukee School District. We really appreciate the donation.
Thank you.
And I just wanted to make a note for the record. We will be, we're going to pass the check back to Mr. Jerry because on the 9th of September, the board will approve it formally to accept it, okay? So we want to make sure things are in order. That makes sense, okay? And that concludes our report. That's fine.
All right, thank you very much. We'll move on to item 7, our public comments. Currently, there's no one signed up for public comments, and I don't see anyone running who is here back to sign up. So I'll wait the standard 15 seconds to allow anyone who might be on Zoom. There should be a link in the chat if you'd like to sign up to address the board. Should use it for while I'm waiting. Okay, seeing no new signups for public comments, I will close it at this time. And we will move on to item 8, our board reports for the evening, starting with 8.1, review of the board calendars. Today is August 26th. 6 p.m. we have our regular Board of Education meeting, and we also have a financial stability and efficiency workshop on health insurance. Monday, September 9th at 6 p.m. we're regular Board of Education meeting, and we also have our public budget hearing that evening. And then Monday, September 16th at 6 p.m. we have a board workshop on sale continuous improvement. And then on Monday, September 23rd at 6 p.m. we have a regular Board of Education meeting. Moving on to board committee reports, starting with 8.2.1 employee engagement and culture. Mr. Keller's not here, so who's Mr. Burns?
Thank you. So the way of doing both of them here tonight. So employee engagement and culture. We met on the 20th of August and Dr. Robinson stole my big talking point. So I don't have much to report with it just being a 1.5% for our vacancy rate right now. So really good news leading into the year for us. We also talked about our teacher opening day, which obviously, you know, is passed for the 21st when we were meeting on it. And so that's for all of our new teachers and getting in oriented to the district. And then the other part that we talked about was that we have 11 interns that have signed up with the district this year. Pretty much all of them in the elementary school. We do have, looks like one in high school, but then that would be about 10 that'll be going around the elementary schools. So some really good things going on with that. And the last piece that we touched on is we have been working on doing a substitute survey to kind of see how things are going and see if we can gauge how we can bring substitutes in more consistently. We did a quarterly survey last year, and we're looking at getting in a little bit of a mini survey. So it's just kind of by appointment. You come in and one or maybe two questions, just give some feedback so we can try and collect a little bit more information and keep people coming back as subs. And other than that, it was a very short meeting. So that is all I have to report.
All right, any questions for Mr. Burns regarding his report? I had one. I know we have building subs. Is the 1.47% vacancy rate including building subs or excluding building subs?
It's excluding building subs.
Okay, do we know where we're at for building sub fill rate?
I would have to get back with you on that number.
Okay.
But we are making progress on it. I don't know the exact number.
I know the criticality of building subs for being able to help with things like sudden staff shortages or even long-term staff shortages. I'm not shortages, I'm sorry, absences. And so being able to have them in place, I know is very important and take stress off of the other staff with and obviously take over those duties if we do not have a building sub in place. So thank you, Mr. Burns, for talking about subs because it reminded me to ask that question. See, knowing what that's building sub rate, fill rate is. And do any buildings have more than one?
High schools,
Which
High
one?
schools have more than one?
high schools and.
I don't think with hires though. I think they have
Oh,
more than one
Sorry,
position.
more than one
but-
position, yes,
correct.
correct.
Okay,
Sorry.
but
my
not more than
apologies.
one missing.
Correct.
But there could be some buildings that don't currently have a building.
That's
sub.
correct. That's correct.
Any other questions for Mr. Burns regarding his reports? Or additional items for future agendas? Seeing none, thank you very much, Mr. Burns. Moving on to 8.2.2 financial stability and efficiency. Back to Mr. Burns.
So financial stability and efficiency met on August 19th. And we also had a relatively short meeting compared to some, but we touched on our health insurance follow-up, which we're going to be talking about here tonight as well. So more of that to come. We also had a topic of early admission kindergarten brought up, talking about why our current position is the cutoff that we have and what can be done to maybe adjust or accommodate kids that are ready to start before that time period. And so we're going to look into a couple of pieces of information for both just research wise as far as starting, but then also getting some teacher feedback to see what their thoughts are as well. And so we'll be exploring that in the time to come. We've also been exploring the athletic busing issues that we've had where students are leaving school quite early in order to get to events and not just athletics, but any extracurricular event that they have to go to. And so we determined that we need a bit more information on that as well. And so we're going to try and flush out some more numbers both with how many people are moving, how many times we have lots and lots of people moving on the same day, and just kind of see if we can figure out any patterns so that we can figure out some solutions to the issue. So look for more of that to come. Our enrollment, we also touched upon, and we're in a good place on that. As of last week, we were a little low, but that's normal for the beginning of the year. And as we get in, and it was about 200 students short, but historically that's a good place to be. So we're in good shape. And that is the end of my report.
All right, any questions for Mr. Burns regarding his report?
And that, just to clarify, that 200 low is just for the enrollment process. They completed the online enrollment process for everybody at home. Okay, so that means that we have to, and when I received the report today, put a message out to the coaches, get with your principals. Need to get on the phone, start calling parents that have not completed that open enrollment. I'm guilty. I'm one of them. So just, yeah, the online registration.
Any questions or any future agenda items for Mr. Burns' committee? Seeing none, thank you very much, Mr. Burns. Moving on to 8.2.3, Recreation and Community Services, Mr. Becker.
Thank you. The rec committee met last Monday, the 19th. We had a little bit of discussion on our project with the strategic plan for the district. Unfortunately, we are not going to make the original timeframe. That the draft won't be completed, but we anticipate completion this fall. So it'll be kind of a soft launch, a bit of a really refined draft, but definitely not a final form. It'll be subject to modifications throughout the semester and the school year. We also spent some time talking about staffing through the rec. We spent some time talking about full-time staffing and some of the changes to manager positions just to equalize the load for the multiple managers that we have. There was also some discussion on the summer staffing for the summer camps. There were some positions that had to be filled on short notice, and that put some younger kids into positions that they weren't quite ready for. So we were discussing ways to avoid that and be better prepared in the future. We had some brief discussions on the construction as well. The original rec center renovations are about done. They'll be finished mid-September. Irving is on track as well. And we did have a nice discussion as the whole group saw last week with the lane walkthrough and the building updates there. And I believe that's all. Yep, that's all we had.
All right, any questions for Mr. Becker regarding his report? I just had one regarding the strategic plan. Is there any particular piece that is proving to be more complex, or is there something they're waiting on before we can add something, or what is the delay in your eye?
Some of it is just being able to connect. People with busy schedules in the summertime. It was difficult to find times to meet. You know, not everybody's got the same availability. People are out of town. And some of it, we had some leadership questions too with one of the group. We had a leader who was maybe going to be leaving, but
Got it.
basically summer just got busy, and I think rather than turning in C work, we're looking to turn in some A work.
Got it.
Something that's a little more comprehensive rather than rushing it. We'd prefer to have it be higher quality.
Okay, all right, thank you. Any additional items for Mr. Becker to consider at future agendas? Seeing none, thank you very much, Mr. Becker. Moving on to 8.3, board member reports, community events and events board members attended they would like to report on. Ms. Kaiser?
I was able to attend the new teacher meeting, which was fantastic. I think I met every single person. I was really impressed with how excited they were to be here. Battle of the Dogs was really fun. Another year of slinging chips at kids this year, I guess. And then I also attended something else that makes me completely forget, but it was a good time. I'm sure.
All right, thank you very much, Ms. Kaiser. Anyone else want to report events they attended? Mr. Becker?
I also made it to the new teacher event last week, and then the first day for all our teachers this morning. Really, as Dr. Robinson said, really high energy. That was great to see. Also made it to the football game Friday night.
Yeah,
It's a good time.
all right, thank you very much, Mr. Becker. Anyone else want to report events they attended? All right, well, I also was able to attend the new teacher meeting that was held last week, and the welcome back event that was held today. Very high energy in both situations. It was great to see all of the administrators there as well, cheering on their staff and being a focal point of goofiness, which I think is important for leaders to do from time to time. As board president, I am honored to be able to speak at both of those events, so it's always something that I try to take seriously to provide some input from the board side. 'Cause I may never talk to some of those staff ever, I've never seen them. And so it's important, I think, to kind of hear perspective from us as the board. So I do appreciate those opportunities. I also had fun slinging burgers at the Battle of the Dogs and watching the game afterwards. So a lot of fun times in that regard as well. I'm looking forward to the back to school batch that we have coming up here on Wednesday. So we'll see a lot of our community out there as we really kick off the school year here as we're coming up next week. All right, so that is everything. That really kind of was 8.4 as well. And we'll move into our consent agenda this evening, starting with approval of minutes from our regular Board of Education meeting on August 12th and our board workshop on August 19th. That's 9.1. 9.2 is an employment summary. 9.3 supplementary contracts, and 9.4 our financial summary. Does anyone need anything separated out? Mr. Sikich?
I need, excuse me, 9.3. I'll have to
9.3.
recuse myself on that one.
Okay, all right, so I would look for a motion on 9.1, 9.2, and 9.4.
Move to approve.
Second.
Moved and seconded. Any last minute discussion? All those in favor?
Aye.
Opposed? All right, that passes. And then we look for a motion on 9.3.
So moved.
Second.
All right, and Mr. Sikich, you're recusing yourself on this one?
Yes.
All right, so all those in favor?
Aye.
Opposed? All right, that passes and one recusal. All right, so we have no action items this evening. So we'll move right to our workshop on health insurance. Did you have a preamble?
No, let's get right into it.
All right.
Great. Well, thank you again for having us back this evening as a follow-up to our first workshop, kind of workshop number 2 tonight. Hopefully here to answer and kind of provide some direction and have a discussion tonight. So with us again is Brown & Brown Consulting, Chris Messer to my right, Lorenzo Di Matteo to his right. They'll be here to kind of support and facilitate the conversation and answer any questions you guys have. The goal of tonight is for you guys to authentically have enough information to be able to make a decision here in the next couple board meetings around kind of what that looks like for both staff and pre-65 retirees getting into January. So I passed out a packet. This is not every slide that's in the slide deck. We'll have points where we'll turn to it. It's easier to read on paper, I think, some of the things. And we'll have some built-in time for questions. So I'm going to try to go 29 slides every 5 or 6. We'll ask questions that way. Feel like you guys get to the bottom of it. So we'll jump right in. So the agenda tonight, I want to talk through the timeline and background, kind of what got us to here tonight and kind of, go through that a bit. I want to just spend really a few seconds in hitting on all employee benefits, just for you guys as board members to kind of know what benefits all of our employees have access to in the district. I think it's good for you guys to know kind of what those look like, and certainly Lorenzo or Chris can speak to those as well if you have questions. We'll talk about the loss ratio by group. That's not new information. You guys have heard that before, but a quick refresher because that's kind of what drives everything we'll be talking about. We'll talk about the renewal we received from UHC, kind of if nothing changes perspective. And then we'll talk about the RFP process that Brown & Brown went through. We'll discuss the UHC ACO network and kind of what that is and how that's a different renewal rate. And then how does that impact employees? We'll spend most of our time on that. And then obviously at the end will be final considerations for you guys. And then, if there's enough, if there's enough information for you guys to make a decision in future meetings, or if more information is warranted, I suppose. So jumping in, I think it's good to level set. What are the priorities as a district around employee benefits? So number 1 and 2, I think, go hand in hand. Our goal, I think, from a financial perspective, is to maximize employee benefits. I think employee benefits have been one of the shining stars, I would say, for employees across the district, dating back to, 30, 40 years ago for employees. So I think trying to maximize those and maintain those really in a really, an uneasy environment has been a challenge, but we've been able to do that. So I think that's been the number 1 priority from a district perspective. And then number 2, kind of going hand in hand, is costs. That's 1 to the district and the employee, because there's a 90-10 split there. And then if change is needed, we saw this with UHC, like how much disruption happens. So trying to move through change without disrupting people's lives, that's certainly the number 1 focal point. And then obviously if you change too much and it impacts people too much, considering employee retention, which has been at the focal point of our work, I know, here as a team. So kind of level setting. Timeline, we've been talking about health insurance since really May. We discussed it at the FSC committee in May and June. We had a workshop in July with the Brown and Broughton team here on the state of health insurance. I think kind of like, what's it looking like everywhere else? It's indicative of what it might look like here, right? And so kind of getting into the weeds there was, I think, needed and helpful. We discussed it, as Brendan mentioned, on the 19th with our committee last Monday. And we're here tonight, and then tentatively, pending your guys' feedback, we'll look for some action either early September or late September. We would be looking to make a decision by the end of September because open enrollment for January really starts in November, which means communication starts in October. And if change is happening, then you want more time for meetings and giving staff time and opportunity both during work time and after work time or virtually to have access to that. A lot of people, their significant others like to come to those meetings too. So trying to create time and opportunities for those is always helpful. So on it, I'll point to your packets when there's a slide in here. So this is page 2 in your packet. I won't spend a ton of time on this, but I'll kind of go over this briefly. If you have questions after this, you guys feel free to ask, and Brown and Broughton team can answer those. So this is kind of an overview slide of what are all the benefits employees have access to. These are active benefits. Some are retiree benefits. So you can see on there, number 1 is our UHC medical benefit. We have a retiree direct bill benefit for our retirees to be able to kind of make payments and things like that. Dental, we're self-funded. That's a district paid benefit for staff. Vision's an employee paid benefit when we bargain as a group. So we get, I think, really good coverage for our employees. I think it's almost better than almost every area district for a really decent rate for staff in the district. We have a basic and optional life insurance. We have short-term, long-term disability. Not every school district has that, but offering that. It's employee paid, but again, you have to be big enough as an organization to get organizations to do that for you, right? So that's a good benefit. We have the worksite. I'll kind of pass up with that one. FSA, COBRA administration. So we work with a number of organizations. So you get a sense of kind of what we have. The clinics on there, the HRA program through OPEB, and then because our wellness funding we get from UHC is more than the clinic expenses, we did offer this year gym membership reimbursements up to a certain cap for staff. So it's been well received, I think, out of our new employee benefits. New employees typically are younger. These things typically, as we've discussed, matter less to them now, right? But that was kind of a hot commodity after we left. I think Lorenzo and I and Jessica got, 8 or 9 people come up to, how does that work? And when did we hear about that? So it's kind of a good benefit that we can offer, especially through the renewal when that's likely not going to change. So any questions on employee benefits, kind of overview? Okay, we'll keep going. Okay, so the loss ratio, these next few slides are in your packet too, so feel free to look through these as we go. So the loss ratio, as we discussed in July, for all groups, actives and pre-65s, including any plan you take, base or BAP, we'll get into the details in a minute. We had about 113.5% loss ratio. So, in the private world, organizations are looking for 80-85% because at 100, you're essentially balancing out for $100 in premiums to $100 in expenses. The 0 is 100% loss ratio. So for an organization like UHC that's for profit, they can't just wash out premiums and expenses because they don't make any money then, right? That's kind of the thinking. So if you think about 80% loss ratio, 80-85, and you get to 113, you might have seen in here that a 30% renewal. I mean, you can kind of do some like quick math. That's kind of how I've learned to think about it. So that's just kind of the loss ratio drives renewals, right? And I know it's more detailed than I'm making it seem, but I know Chris and Lorenzo can speak to that specifically, but that's generally when organizations like school districts or private have fully insured coverage. They're looking at what's our loss ratio? How do we lower that, right? Worksite clinic, things like that, cheaper options to get suitable care is really what you're looking at. And I think as we get into the ACO discussion, that's where really we're driving people to cheaper options is the point, right? So the next couple of slides kind of gives you a quick breakdown of who's driving the loss ratio, right? In terms of usage. So we offer in the district 2 different plans. We offer a base plan and a buy-up. The base plan is going to be lower premium, higher deductible. You're going to pay less per month, but when you go, you're going to pay more, right? The base loss ratio for the year to date was about 78%. So as you compare it to 113, you go, well, 78% is pretty good, right? It's well below 100 and certainly below the 80. So from a claim perspective, you can see $2.7 million in premiums, about 2.1 in claims. The math is good there, right? As you go to the buy-up plan, this is all employees again, all active and pre-65s. you can see that the loss ratio jumps to 154, almost 155. So again, the buy up is a higher premium, lower deductible. So people that generally pick that plan are going to go, well, I'm going to use the insurance, so better to pay more per month. They do the math, the premium times 12 months, add on the deductible. How much is that versus the base, right? So then people that are picking the base are going, well, am I really going to use all the insurance this year? Am I going to match? They're kind of like forecasting out the year, right? Oh, last year we had a good insurance year. Maybe I'll do the base again, save $100 a month. It's a personal decision based upon your family. Totally understand. You can see here the premium and claims is almost about a $1.25 million difference, right? The other way. So then if you take the same groups and you break out actives versus pre-65 retirees, you can see the loss ratio for the base and the buy-up, but just active groups is about 107.5%. So about 8% less than the whole group at 113.5. So you can see here the premiums and claims are still upside down because we're still north of 100, right? But you're much closer than what you were during the buy-up at 154. So I think it's a little bit more than $300,000 of difference between premiums and claims, right? That kind of making sense, the 100. When you look at pre-65 retirees, you can see the loss ratio jumps to 166. Again, this is not new information. We discussed this, but again, to kind of recap, the difference in premiums, again, you can see it creates the loss ratio at 166%. So all of that led us to kind of the renewal. We didn't have this information in July, and I think that's kind of we were working through what that was going to be, and then what was that renewal going to be with the ACO in conjunction, waiting on the RFP results. So I kind of explained this to my committee as almost like it's car salesy-ish. So they have a rate calc, and I know Chris and Lorenzo can speak to this in a second to explain more than me, but the rate calc came out at 56%, right? And then it's like, well, before you leave, I'm not buying the car at 70 grand. I can sell it to you today for 52. Okay. Well, then it came to 30, right? So 30% increase, 29.9. It was contingent with the wellness clinic funding. I mean, obviously from a wellness perspective, UHC is saying, hey, it's better for us if you have it. So if you're going to take a rate reduction from 56 to 29, we're gonna mandate you take it, because the clinic goes away, it's gonna impact our loss ratio because people are not gonna be able to go there. They're gonna have to go to urgent care. You can kind of see the dominoes, right? It also is contingent on having the nurse liaison, which makes sense, thinking about it from a loss ratio perspective. And then the breakdown, again, if you took the 29.9 and broke it across actives and pre-65 retirees and said, well, how would it break out if you split them, you separate them? It go roughly 28% for actives and roughly 50% for pre-65 retirees. So a small number of people incurring a large number of claims, right? Anything to add, Chris, Lorenzo, on that? I just wanted to see if I missed anything on that.
No, I think you did a great job.
Okay.
So,
All right, the car salesman thing's a good analogy.
well, realistically, so since you said it, I
Yeah.
mean, certainly not a car sales operation, but what, United Healthcare and other insurance carriers do, they have their underwriting process for calculating fully insured renewals. And then that incorporates any number of variables, some kind of static information. But then what also matters too is the interest in partnership. What's the total claim or premium value here? What's the size of the group? Because that means something to them from a negotiation perspective. What's the rest of their book of business look like? What's their new business? What's the renewal book look like? So there's a lot that goes on that we don't necessarily have insight to. That's why you'll see calculation and then a released number, right? They go through kind of that business decision. I can tell you before they release your renewal, their entire executive leadership team is meeting and talk about you. You're a big group. You're very important to them, important partner. And that's why there's a 26% decrease from calc to actually release renewal being presented. So.
And so to kind of jump to like, well, what's the problem, right? Beyond the budget, from the district perspective, what's the larger issue? And you trickle that to employees, right? And I think this is like the conversation we've been trying to work out internally is how do you make it work for people, right? Because employees still pay 10% of that increase. So we kind of went through the notion of if an average teacher makes 55,000, which is about where things are at next year, including the 5% after taxes, it breaks out into about $143 a month, right? So that increase is like pretty much taking a large chunk of that away if they take a family option. So it's just, it kind of moves people backwards, right? And so that's where we've been trying to figure out a way, can we still make it work without moving it backwards? Because employee compensation has kind of been a focal point of our conversations for the better part of 2 years, right? So that's just kind of where things were at with that. So moving on to the RFP process, so that's certainly an option still. The RFP process, maybe I'll let you guys speak more specifically to the RFPs and kind of what we got back.
Yeah, absolutely. So as part of the RFP process, we send your claims information, because that's obviously what's needed for them to evaluate your population. We send an RFP document that outlines kind of some of the history of the district, where you've been in the past, and then the current payment signs that you have, and then ultimately the market will evaluate that and decide if they want to provide a proposal to the district. If they do, then we analyze that and provide that as a summary. Some of the market, has the opportunity to come back and say, based on the experience, we're not interested in providing a quote, and then in that case, they're just declining to quote. I know Chris has talked about it in the past. The fully insured market in both in the state of Wisconsin and even nationally has been dwindling in terms of the carriers that are in it. So district historically for a long time was with WBA Trust. They went out of the marketplace, and then shortly after that, I'm sure a lot of you are aware that Humana has left the commercial insurance marketplace as well. So that's really left, only a few players in this market that are able to really provide a proposal for the district. And we really went to all the viable carriers that would be possible, or we would want to consider based off of their demographic and footprint here in the state of Wisconsin. So that group's included Network Health Plan, Anthem, and WPS. We'll get into the Network Health Plan proposal in a second, but Anthem and WPS both declined to provide a proposal based off of your experience. So they said, based off your experience, we don't anticipate we could provide a competitive proposal to you as a district, so they declined. Network Health Plan did provide a proposal, and you'll notice there's two options listed here. One is it's point of service, or POS, and one is HMO. Network Health Plan is provider owned, and basically their network is pretty inclusive of almost everyone except for Advocate Aurora. So all of their networks do not include Advocate Aurora as an option for an in-network provider, which means that to go to Network Health Plan, you could move to the POS option, which would mean in and out of network benefits, and Advocate Aurora would be out of network, or the HMO option, which just basically means there are no out of network benefits, which means there's no coverage for Advocate Aurora at all. So you'll notice, for example, the network health proposal was a 36% increase from current. Again, that would really match the current benefits, but Advocate Aurora being out of network. And then Network Health Plan HMO option, no out of network benefits at all, 12.1%. So obviously that percentage is much more appealing than the United Healthcare renewal, but the actual impact when we look at your utilization of the district for your members, as you could imagine, removing Advocate Aurora from an option would be a major disruption to you and to your family members. So,
And it wasn't something that we really considered too deeply. I know when we shifted from WA to UHC, it was like in the high 40s of people that are actively using Advocate Aurora. So if that has held true, I'm sure it has, of people that use it. I mean, you've been looking at an almost 50% disruption rate for people who use Advocate Aurora. It's pretty widely used in our district, I think. So, okay, any questions on the RFP or the original bid? We'll shift, if there are none, to the ACO. It's kind of the halfway point here. No, but
So we've been given the 29.9% from UHC, and I know in the past, we've gotten the rate and we've kind of go back and forth, and there's like negotiation beyond that. So is the 29.9% after negotiation, or is this the first offer that we've been given?
So I will tell you, speak on our behalf here. We've had extensive conversations with United Healthcare. This is a very aggressive post-negotiation renewal proposal. So well before we got the proposal, we were working with Aaron to shoot to be as aggressive as possible. We gave UHC some targets to try and get to, and we were aiming for something really in the single digits, knowing that trend in general is 8 to 10%. 30% is the best United Healthcare could get to without plan design changes. So this is post-negotiation with a lot of negotiation. Bottom line is United Healthcare is not going to move any further. part of it is the shrinking carrier market, but part of it too, if you recall from one of our prior workshops, I had mentioned that we've seen a tightening in the market of interest in school district business. Part of it is there are two primary reasons. Historically, rich benefits that are highly utilized. That's exactly what we just talked about a couple slides ago, right? We didn't get into the plan designs per se, but utilization rate is very high. That's exactly why the carrier market has tightened up in an interest in school district business. When I say that, some carriers will still provide proposals. We're seeing that here. Others aren't interested. But historically, even going back 2, 3, 4 years ago, we could go to the carriers and say, hey, we've got competitive offers in the marketplace, at least one with a multi-year rate guarantee, or a rate cap year 2. Let's talk. And we had options. We don't have options anymore, and that's what you're seeing here. So sorry, that's a little bit extra on your question, but yes, this is post-negotiation.
Okay. No, it's important, I think, to, we're not taking the first offer that comes to us, right? Like, this is something that's come through a lot of different avenues. And the other point that's very important is the fact that we've lost carriers in the market. And so that we don't have, basically we're getting down to monopolies at this point.
Yeah.
There's only so many people who are in commercial insurance. And then of those, there's only so many companies willing to work with school districts to insure them. And so you're dwindling down your options more and more, which makes people less likely to negotiate, right? Where else are you going to go? So I think that's the point I think it's important to bring across here is that, number one, this is not the first offer. And number two, this is why it's in part as high as it is. We aren't able to negotiate as much as we were before with WA, where it would start here and end up here, where we had single digit rate increases for 5, 6 years in a row.
Yeah, and to be clear here too, so there are other fully insured carriers in the state, but they're just not viable options or completely off the table as far as options for West Dallas, West Milwaukee. So just in case you've heard of other insurance carriers out there, there are other options like Prevea, for instance, up in northeastern Wisconsin. Prevea has an insurance plan, Ports has an insurance plan, but none of those are viable options for West Dallas. That's why we didn't look at them.
Because they're regional.
Correct.
They cover regional carriers.
Correct.
All right, we're gonna jump into kind of what is the Nexus ACO plan. This is, I believe, there's a slide, that's kind of a transition slide into the ACO plan in your packet. So the ACO plan, essentially what United Healthcare does is they take everyone that's in network and they break them up into tiers. And so my understanding is certainly they're working as a large organization. They are working with different hospital systems and essentially negotiating the best rates they can for the people that access their insurance. So organizations that, work with them and I guess cut the best deal for, services that people use get put into different tiers. There's 2 different tiers. Those tiers are consisted of Advocate Aurora, Children's, Freighter, Medical College. I think the only exception that's Freighter itself. Kenosha. And then everything else is considered a tier 2, still considered an in-network benefit, right? So everything that was in network is still in network, but as part of the ACO, they require plan design changes to that tier 1 and tier 2 benefit. Currently, a good example, we have 100% co-insurance after the deductible. That is the same plan as the ACO, but then that's only under tier 1. Tier 2 providers are still in network, but after deductible, it's an 80% co-insurance, right? That's an example of a required benefit change. So anything other than that on the differences between tier 1 and tier 2?
I would just say in general, think about it this way, and you did a good job of describing it, but tier 1 and tier 2 under the ACO added together are the same in-network benefits you have today. All providers, generally speaking, tier 1 and tier 2 under the ACO would be in-network under the Choice Plus today. Again, so just really segmenting those in-network providers between the ACO, which stands for Accountable Care Organizations. These are organizations that are financially incented to better manage population. With United Healthcare, there are 2 financial, I would say, values there. One is improved contracting. Secondly is improved patient management or population health management, which results in improved outcomes and hopefully manage costs long-term. So those are really the 2 value props of the ACO itself. And to Aaron's point, Freighter itself, even though it's part of Freighter, it is a separate legal entity. Therefore, under the circumstances can be separate, and it is tier 2 under the ACO, but it is not in the ACO network.
Can you just explain on where it says outside the counties, tier one providers follow premium designation? Like, we've been up north before with my kids and the one gets sick and we had to go to the hospital. Would it just be whatever hospital that's like the biggest for the region count, or like, how does that work?
That's a great question. So, Nexus ACO, although there is in southeastern Wisconsin, you'll see the counties listed that are part of Nexus ACO. It is there's Nexus ACO areas throughout the United States, so,
Okay,
but I'll get it, this will help you answer your question too. So based off of the care you receive, where you receive care, okay? If you're in one of those counties listed here in blue and listed on the slide, then they received a tier one benefit. You either have to go to a Nexus ACO provider, or there are certain benefits as well that Aaron's gonna go up to in the next slide that are not a tiered benefit. So emergency room, for example, that's not gonna be a tiered benefit. That's gonna be the same if you're in a tier one or tier two. Urgent care, they'll be tier one or tier two. Mental health providers, tier one or tier two. Those are not tiered benefits.
okay.
So it's not for everything specifically. If you are though receiving care outside of the county and you're going to receive care or the counties here for a tiered benefit, like a primary care certain specialists, United Healthcare has what's called premium designated providers. And today, if you have a member that goes and searches for provider on UHC's website, there's providers that have two blue hearts next to them. And they're called premium designated providers based off of the data that UHC has regarding the care that they provide to their members. And so if you're going for a tiered benefit outside of these counties or non-Nexus ACO market, you would just go and search for provider with two tiers. And then you would still have the tier one benefit level.
Great. I was
Yeah, it's a great question.
concerned about ear because we always end up there on Thanksgiving or something.
Yeah, no, absolutely. And then the other part as well, so you'll notice on the slide that it says PCP selection required, so.
Yeah.
At the time of enrollment, United Healthcare, or after you enroll, they'll follow up, you'll get your ID card, it'll have. A barcode on it for you to go to a website and select a primary care physician. The reason for that is not because you need to have a referral to see a specialist. In order to see a specialist, a referral is not required. The reason for that is they want people to designate a primary care physician, because if you do designate one, you are more likely to utilize that provider. We know, just in general, majority of people are medically homeless, meaning that they do not have, a relationship with a physician. We're fortunate enough to have the clinic here at West Dallas and that PCP, services being rolled out, but still, there are still many members that do not have a primary care physician. So that's the reason for that PCP selection. It's not, again, required for referrals. It's just so people are designating that even on their ID cards, it will list the name of their primary care physician.
So to recap, so the ACO plan, everything that was in network's in network. It's just there's two tiers, and with plan design changes, we'll talk about that in a minute. It requires you to designate a primary care physician. And then on this slide, you can see all the benefits that don't fall under a tier, any tier, right? You go to the ER, as Lorenzo mentioned, things like this are not considered tier benefits. Okay, questions?
Does designating a primary care physician require a visit? Or can you just say, I picked that one and that one's good and like you get in?
It does not require a visit, but there may be some primary care physicians that are not seeing patients.
Sure.
So then when you go on to the website with United Healthcare, for example, you would see who's accepting new patients. You can select from that list, or if you already have one, you would just know who that PCP is. You don't have to go though, to your point, and have to visit in order to designate them.
In the clinic we have can allow staff or their benefits or the dependents, sorry, to designate them as the PCP too.
So if you already have someone who's on the list. If we pick this option, if there's an employee who already has a primary care physician that's on the list. They just pick that person and with that basically identify it on there and then they're done.
Yeah, so you'll have, I believe it's either 30 or 60 days to elect. And if you do not elect one, what happens is UHC is just gonna designate one for you. So they'll resend you a new ID card with a PCP listed. Again, it's not saying that, and it's not requiring you to see that person. It's just so getting that person to think about, okay, if I have to see primary care physician, there's a name on my ID card at least here that I can at least call or again, or go at least go to the clinic for primary care.
Yeah, it seems counterintuitive. Why would I have to name a primary care physician when it really is of no consequence? But that's part of the strategy. UHC has a different strategy. It's more restrictive, but in this case, again, as Lorenzo mentioned, really United Healthcare just wants members to be more engaged in their health and their care management and, identifying a primary care doctor at least. So for that.
Okay, so we're gonna jump into kind of like some quick definitions. I think it might help us to look at the plan design changes that they propose under the ACO. So I'll let Chris Lorenzo talk through these three, because these are the three areas as we talk about the plan design changes that'll help kind of guide the conversation to see the differences between, oh, what is it today versus what could it be then, right? Examples.
Yeah, I'll just start with the deductible. So I know on the slide notes the amount you owe before services begin payment, but one thing to keep in mind is that the district plan is what's called the PPO plan, which means that you have co-pays, which will cover services after that copay. So you have primary care specialist co-pays for other like labs and other services. So in that case, you would pay those co-pays. And I'll get into that out-of-pocket maximum, but those co-pays do not apply to the deductible. Those co-pays apply to the out-of-pocket maximum. What happens is the deductible, you have an inpatient or outpatient stay, for example, your procedure for outpatient, that's where your deductible is going to come in. So that you would be responsible to pay that deductible amount, whether it be the 500 today for the base plan, 1500 for, or sorry, 500 for the buy-up, 15 for the base plan. And then once that deductible is met for that service, that for example, hospital stay, co-insurance will begin. The district today in network has 100% co-insurance. So what that means is if I have the base plan, $1,500 as a single, as soon as I've spent that $1,500, the plan, United Healthcare is going to pay 100%. So as long as I'm in network, which means I have no out-of-pocket exposure other than copay. So after that $1,500, my primary care visits that are not preventive, my specialist visits, my other copays are all going to apply towards that out-of-pocket maximum. The deductible that I've spent also applies to that out-of-pocket maximum total number, okay?
And I think that's why it's important to note that in a non-100% co-insurance environment, when you hear the percent, 80% after deductible, that's where plans, the question under those plans is, what's the out-of-pocket max? Because now you're looking at what's the total damage. Go to the ER for something, you're there for a couple of days. My deductible is $1,000. Well, that's great. But if you don't have 100% co-insurance, it can be meaningless, right? Under our current environment, our employees are really only privy to the deductible and then the co-pays. So it's really difficult for people in 100% co-insurance. Even the deductible is $10,000 to get there because you're only paying the co-pays unless you're going out of network, right? So you guys follow that? I just think it's important looking at the current plan to what the proposed changes are to kind of level set that before we jump in.
And the other comments, so related to prescription drug coverage, there's co-pays under the plan today, depending on if it's brand, generic, or brand or generic, for example. And then today, the prescription drug co-pays go to a separate pharmacy out-of-pocket maximum. So for a single, it's $2,000, $4,000 per family. So those co-pays today do not track towards that medical out-of-pocket maximum. It's two separate out-of-pocket maximum. So as we look at other options that we're going to be talking about, that is another change. Yeah, that would be a benefit to bring those together.
So I want to spend a few minutes on this slide, and this is really going to try to get you guys into what the current plan is versus what the proposed ACO plan. And again, there's two different options we have as a district. We have a base and a buy-up. So the first column, I'll try to go through it, and I have it in the slide deck here so you guys can look at this a little easier. The first column is kind of a guide to show you as you move across. So it starts with medical benefits. You see deductible top left, single family, deductible type. You see out of pocket as you work your way down. So that's column one. Column two is the column 2 and 3 are our current plan, base and buy-up. That's as it exists today. Should the board want to move forward with a 29% renewal, that's what would be in place for the following year, right? When you move to columns 4 and 5, you're looking at, well, what would it look like under the ACO for the base and the buy-up? So really you're comparing column 2 and column 4 and column 3 and column 5. And as you read across them, whenever you see something red, that would be kind of a deducted, like a negative change, you could say. And black would be really no change, or is no change. I shouldn't say really no change. And then green would be an enhanced benefit for employees, right? So, I want to just pause there and make sure that everyone kind of is on the same page looking at this, so you can take a look. So you can see, I'll kind of go through an example.
This was helpful.
So you can see column 2, the base.
Circling them.
Yep.
The 4, yep.
So you can see the column 2 says United Healthcare base plan in network is a 1,500 single, in network deductible is 1,500. Everyone see that?
Yep.
And then the base under the ACO goes from 15 to 2,000, which is why it's red, because it goes up $500. You can see that the family in the same bracket is 3,000 and the ACO would be 4,000. Shifting into the buy-up as it currently is, the single deductible for single deductible is 500 and the ACO buy-up, it's still 500. So that's why it's black. And you can kind of work your way through it. If you look through, I kind of created a short slide here. I'll jump back. The main changes for the base are that deductible increases $500, out-of-pocket max jumps 2,500 in network. You can see there's co-insurance tiered. So if employees remain with tier 1, 100% co-insurance, which to me is really, really important to maintain that benefit for people. Quality care at a like predictable price is really what we're going for, back to priorities. Tier 2 does require 80% co-insurance, so that will create some disruption for people who go, well, my PCP is currently in a tier 2. Can I still go? You can, but it will come at an added cost to you when you could change to tier 1, right? Things like that. And then you can see for copays, there is some good news, right? Copays, there is some reduced cost there. Primary care decreased in the tier 1 environment from 25 to 10. Specialist in tier 1 decreased from 50 to 40. ER decreased from 75 to 50. And then ER visits, I'm sorry, urgent care decreased. Sorry, my apologies. And then ER jumps from 25 to 500. So there's kind of a theme when I read through this. It is, you can see out-of-pocket max went up, right? Increased, but your copays went down. But in a 100% co-insurance environment, the only way to get to your out-of-pocket max is to be accessing copays and copays and copays and copays, right? ER goes up because they want, as the whole PCP designation thing is, we want people to seek care before it's an emergency. Is it going to happen? Absolutely. People are going to go to the ER. It's going to happen. We want that to happen less, hopefully, right? That's the goal. That's the goal with the clinic. That's the goal with driving people to see PCPs and things like that. And then there's some pretty minor changes with prescription drugs under tier 2 and tier 3. I'll just pause for questions and let people kind of read through this. I think it's important for you guys to understand the changes here and kind of what's being proposed.
Because I don't know, I don't work for the district outside of this. Do we have like magnets for our teachers to put on their fridges to say, you know, health clinic, use it for all these purposes plus PCP? I think we really need to.
Yeah, I don't think we have a magnet, but I mean, the health clinic is advertised and
Yeah, I
we
know.
send things
I know it
out.
is.
Yeah,
Yeah.
I mean, yeah, it's certainly something we could look to market better. That's
Yeah.
absolutely, I agree with that, you know. Yeah.
Yeah.
I mean, I know sometimes there's just no thing you can do but go to the ER because
Yeah.
it's Saturday night, your kid's having
Sure,
an asthma attack, and I've done that many
Yeah.
times.
sure.
But yeah, I see how this plan benefits though. Being in constant care, being in touch with your local people, getting your specialist versus that emergency, which you hopefully, if you get a specialist for asthma, you don't have to go to the ER.
Yeah.
Which is where we are now.
Just a few other comments too, Aaron, if that's okay. So I think one thing that can get confusing with this, I want to clarify as well. So between single and family, you'll notice it says deductible type embedded. And what that embedded means is that if you have a family, now maybe that's you and your spouse, multiple children, each person or individual is capped at a single amount. So say I'm a family and I have my spouse and 2 kids, and I have to go in for a hospital stay, have a procedure done. And I'm in the base plan today. I would have to pay the $1,500 today, and then 100% co-insurance kicks in for me personally. And then the rest of my family has to meet the remaining $1,500, whether it be one person within my family or the other. So it's not that one person meeting the full $3,000 in that example. Another thing I wanted to point out is that like with the Nexus ACO tier 1 and tier 2, those deductible amounts are combined. Okay, so if I go into a tier 2 provider and I have an inpatient stay tier 2. And say that's the new, what's called new base plan or the option we're looking at, the $2,000. I don't have a separate tier 1 deductible that I need to meet. I have now met my tier 1 and tier 2 combined deductible amount. Any care that I receive in either tier 1 or tier 2 will then apply to co-insurance. The difference is then if I go to tier 2, now I don't have the 100% co-insurance anymore. Now I have to start to meet the out-of-pocket amount I'm paying, that 20% amount compared to tier 1 where I'm paying the 100%. Or that's being 100% being paid out. So that's where you start to see the differences. And then I also want to call out that the pharmacy and medical out-of-pocket maximums are combined. Okay, so before today, as it stands, as I mentioned, the pharmacy copays all apply to a separate 2,000 single 4,000 family out-of-pocket max. In the options presented with Nexus, those are combined, which is really a benefit to individuals that have met their out-of-pocket maximum because now I don't have any prescription drug copays I need to pay anymore because it's combined with the medical, or I may meet my medical faster because I have prescription drug copays that are applied to that. So those are just a few distinctions that I wanted to make sure we called out.
So that's important too, because when we talk about the effective change in the out-of-pocket maximum, it's actually, if for singles today for the base plan, it is $2,500 medical, 2,000 pharmacy, so it's actually $4,500 for single out-of-pocket max. In the ACO option, we're talking here with the $2,000 deductible, it's really only an effective $500 increase from $4,500 to $5,000. Okay, that makes sense.
We can come back to this too. I'll
Yeah.
keep going, but the buy-up, same kind of process. You can see there's different changes really that you can see that UHC's, hey, we want more people to go to the buy-up, higher premiums. I'm sure there's connected things there that where you see deductibles changing less, but other things changing more. But similar changes across both plans. So we got into a bit of the disruption rate. So what does that look like? Talking through making a change, one of our priorities was how many people does it disrupt? So currently about 80% of our people already use tier 1 providers anyway. So not that there wouldn't be any change for people in tier 2, but trying to limit the amount of people that would have to make that change for them and their families. I know some people have had the same PCP for years, and that's obviously a difficult thing to have to figure out as a family, but limiting that, I mean, we gave the Aurora example before, certainly that percent's much higher, that user lower than 20%. So really tier 3 out of network, very minimal people are using out of network services. Nearly everyone is in network under UHC. I know Lorenzo added this here. I'll let Lorenzo discuss, kind of go through the out of pocket utilization piece here.
Yeah, so we looked at the 2023 plan year, which is also a calendar year, so January through December. And we looked at both the base plan and the buy-up plan. We wanted to see, okay, if we're going to change deductibles and or out-of-pocket maximums, you know, what is the impact actually to members, especially if we're looking at out-of-pocket, you know, max change. So between the base plan and the buy-up plan, we're using members again, because I said the deductibles out-of-pockets are embedded. So each member, you know, has their own deductible or out-of-pocket maximum that they're capped out at. So for example, on the base plan, the $1,500 deductible in 2023, 131 members met the $1,500. So that could be a spouse, that could be a single, one child, that could be an employee. So that's about 16.5% of the total members in 2023 on the base plan met that $1,500. On the base plan out-of-pocket max, when those 12 members are 1.5%. So as Aaron mentioned, because of the 100% co-insurance and just co-pays, it's very hard to really get to that out-of-pocket maximum. The buy-up plan, a little bit less membership count, but 10%, 83 members meeting that $500 deductible, and then 1,500 meeting the out-of-pocket maximum, so 3.6%. So again, if we're looking at out-of-pocket changes and staying in network at tier 1, you know, really minimal impact in terms of the number of people that are actually meeting those numbers.
And this is important because this is disruption, right? So if this came back and it was 50% of people already met the out of pocket, well, we're gonna have a problem, but it's not. And so I think that's important, looking at how will this impact people? Certainly the tier 1 to tier 2 piece will be disruptive, the 20%. But changing out-of-pocket maxes in a 100% co-insurance environment really doesn't bear a ton of impact to people, not to minimize the 5% you see. So a couple different districts that use ACO, we listed a few. Certainly there's a lot of other private organizations that use this as well, I'm sure, but Maumee Falls, Tosa, Burlington, and Kenosha are just name a few that use the ACO. I think more districts in our conversations are looking at this to try to steer benefits and cut costs and maintain employee benefits as well. So kind of getting back to how we ended the renewal for no changes. So again, we were looking at what is the renewal on the ACO versus the full renewal with no changes. With plan design changes, you can see the net increase, including actives and pre-65s is 9.4%. So there's a little bit difference in the base and the buy-up, but pretty consistent there. If we split the groups out, similar to the prior renewal, with no changes, you can see that actives come in at about 7.7 to 8%, depending on the base or buy-up. And then pre-65 retirees are at about 27% for that. So really the conversation that I think is up for discussion tonight is if that's an option. And I think I have some more information to show to kind of have that discussion with you guys. But majority of you were on the board when we split off post-65 retirees. And it, at the time was for both short-term and long-term kind of financial savings in the district. And so it's certainly up for discussion because at this point, as the gentleman have shared with RFPs, this conversation, there's not like an ACO network version 2. And so if the loss ratio doesn't begin to substantially change, we're going to be right back here in August again next year, having to do the same kind of plan design changes. And next time it might have to be a conversation of, are we going to continue to offer 100% coinsurance? I mean, personally discussing with area business directors, very few do offer that in our region because it comes with high utilization, which comes with high costs and comes with high renewals, right? So they try to steer people really hard to the clinics and, premiums certainly get cut too, but, people that use benefits like this certainly become a discussion. So, and I think by lowering our loss ratio, it allows us to start having a conversation about self-funding, which really is our main point of leverage, I would say, in a renewal on a fully insured market is to, well, we're just going to go self-fund it. And, we don't have to be looking for an 80% loss ratio to make money because we're not in the business to make money, right? So I thought it'd be helpful for you guys to see some more information as we have that conversation. So kind of getting into the OPEB plan, you can see here this graph. This graph shows kind of us dating back to 2019, the number of people that were on our insurance from 19 all the way to the forecasted with the OPEB plan. So 19, 20, 21, this is separating the groups, about 700 people on the plan. Once that was split out, you can see the majority were post 65 and that group was moved to Anthem. That would happen in 2021. So you can see here in 2025, the projected number is 83. That's based on when people term, which is a phrase we use to terming to Medicare, right? And then over time, you can see the projected number will decrease into 2037. The main reason it takes so long is we have two different things at work. When the OPEB plan was passed, we grandfathered people in within 5 years to have the option to take insurance or cash in lieu of, right? People so close, you get the benefit, you can decide. The other piece is that people who retired with kind of the 10-year window for insurance, that's the other thing is some people in this group of the 83 are 56 years old, 9 years to go, kind of run your way right into 2036, 2037, right? So that's kind of the OPEB plan that was board approved 2 years ago at work here. It's also important to know that of the 83, kind of not everyone's in the same boat, right? Everyone's in different positions. So I want to go through that with you to see how that would impact them. Because it's not, the 27% renewal sounds like a lot. It is a lot, but if you get into the details for some people, it's, there's marginal impact to none. So let's start with the 48 retirees. And again, we're on a 90-10 basis. So if the district insurance is $1,000, district pays 900, an employee pays 100, right? That's just the split, okay? And when people retire, that's kind of the deal. And then at benchmark, it changes. And I'll talk about that in a second. So of the 48 retirees that are projected for 2025 in January, right? There are 3 of them that have 8 to 10 years until they're on Medicare. So that's like 57 to 55. There's 19 that are within 5 to 7. There's 16 that are 3 to 5 and 10 within 3 years. the average projected increase off the current plan is $23 to $35 single or 58 to 89, because they're only paying 10% of the increase. So their premium increases 27%. Well, that might only be $89 on a family buy-up, right? So just level setting the dollars sometimes is important too. But really what we're discussing is, should the pre-65 group essentially receive the rate calc renewal based upon their group versus versus active employees, right? That's what we're discussing. So you can see here, this isn't certainly something that I think, I hear 27%, I don't think of $36 a month, right? I think of 400, right? So, okay. Then there's the group at benchmark. So a benchmark means anyone that receives insurance from the district for more than 5 years at their 5th year is benchmarked. Okay, what that means is, if the district insurance, the first year's $1,000, they retire, they pay 100. Then the district insurance goes to, what's an easy math? 150. They still pay 10%. But on the 5th year, the district's portion is locked in at whatever it was the 5th year for every year moving forward until they hit Medicare. So that means if the plan goes from $1,000 to $2,000 in their 6th year, they pay the 100, which is 10% of the 1,000, plus any increase beyond that. The district only pays 900. So this group, by seeing the 27%, you can see the large difference in why. Well, the reason is because they pay 100% of the increase, while as someone who's not benchmarked still only pays 10% of the total plan. So again, trying to break down the details as you guys would need, I would think. 19 employees are affected here. 8 of them are within 1 year of turning 65. Okay, so the exposure there is less for them because they're going to turn 65 in 12 months or less. So when they turn, the benefits are reduced or they're removed completely. 4 retirees are within 2 years, 2 within 3, 4 within 4, and 1 within 5. It's also important. There's so many layers to this. I'm trying to make it really easy, right? 14 of them are on 14 of the 19 are on single plans. And 6 of those 14 actually, even no matter what you do, won't get a change, because when in their 5th year, they were on family insurance. So the district's portion was locked in. Well, now they're on single insurance. So the district's portion is still what the district's obligated to pay is more than they're actually going to pay anyway. So even with the 27% increase, we're still below the number. You catch that? So really, of the 19, only 13 would be affected, and it would be broken out kind of in 8 and 5 and what that could mean for them, right? Hope that makes sense. And then the last group is 16 people retired without the 90-10 split. So a lot of our support staff and the prior plans didn't have a 90-10 agreements. It was more teachers, at-will employees, administrators. That was kind of how the plans were written. So the way their plans were written is that at the time of retirement, they pay 50% and the district will pay 50%. So their portion actually of an increase is less than the benchmark because they already are absorbing more of the premiums should they elect to keep the insurance previously to this either way. But of the 16, 9 are within 1 year, 4 within 2, and 3 over 2. And what this doesn't get into is the breakdown between if a retiree and their significant other, one of them turns 65, they can shift to single. There's things that can happen that I mentioned during benchmark too. So that's another layer to this as well, but it gives you kind of a sense of what would projected increases be for someone, kind of worst case scenario, taking those things into account. Any questions on that before we jump to other districts quick? Happy to go back too if there's questions. So we're getting towards the end here. Yep. Okay, no, one question that came up, and I'll maybe let Chris or Lorenzo speak to this is how does our insurance stack to other districts? This is, I think, in your packet last page, I think. It might not be. If not, I'll get it to you.
It is.
Oh, it is. Good. So if you look at this slide, it gives you a sense kind of comparing our school district to other area districts. And then if you go to the far right column, it has 1,000 plus employees, and then there's school districts. So you can kind of get a sense of, how does our benefit compare to other districts? And using the key that they have here, green and blue kind of show you green is richer than, blue is in line with, and red is kind of a less rich benefit. Is that compared to school district, Lorenzo, or is that compared to?
So the way it's set up is to just go across the board, but in terms of an average between all the sectors here. So whether that be entire block business,
Yeah.
Midwest employers, school districts, in our block or 1,000+ employees, but you can, I think as you mentioned, you can just go down compared to that second to the far right is really the school district focus.
So, I mean, in general, our health benefits are either in line or much better. You know, look at the contributions. I mean, everything's green. The final bottom left corner. So, you know, I just think it's important to note that when other organizations have health insurance, it's the first thing, you know, they don't have a large group to negotiate on behalf of. So it's, I think it makes things more complex for those organizations. So.
Yeah, I just want to add to, so the contribution percentages and the employee contribution dollar amounts are based off of someone not completing a biometric or BHA.
Oh, yeah.
So if someone does complete a BHA, which I know is the majority of your population, did receive a $50 reduction to those monthly costs.
Even better. Yeah.
The other thing to note too, when comparing to area districts is after Act 10, the majority of school districts moved to a 12% employee contribution, which is something our district has not done. So their 10% is not the norm anymore, and it's 12%. I don't know exactly if there might be some 10% still out there, but the vast majority I know did go to 12.
Yeah, there are others that do more than that as well. We've seen some less, but yeah, 12% and up, I'd say is much more common.
So kind of just level set the conversation a bit there. So I guess final considerations, and then hopefully questions, discussion, kind of finish up here. So like dating back about a decade, our loss ratio hasn't seen significant changes to it. I mean, we've put some things in place. There has been some adjustments to that, but I guess what I'm getting at, I don't expect this to change pending some of the ACO things that will get in place. If more people are steered using tiered benefits, hopefully that will just have natural increase, but not something that I would expect. In 22, we moved, as I mentioned before, post 65s to Medicare Advantage. This clearly provided short and long-term savings for the district and really sets us up for long-term success, similar to the OPEB plan by 2037. As Brown and Brown had mentioned, there's just less people in the insurance environment. So negotiation, leverage, things like that are difficult to do. So really without a viable option, you know, fully insured is kind of the place we're stuck in at this point. So addressing the loss ratio is in the best interest of the district, long-term and short-term. So having self-funding be an option next year, the year after, or in the short-term future, I think even to have it as an option is important for us because I don't know how to get control of that back. Healthcare costs, we've discussed, are, you know, the top few reasons for nationwide inflation. There's even been articles written in the New York Times as they've discussed with us that like they go as far to suggest that there's the federal government inflating health insurance costs, and we're happy to send that to you guys as well too. But just it's a reality. And I think that the last thing I'll point out here is that we were only able to get to a 9% renewal by making substantial changes. So if nothing happens in a year, we'll be discussing, well, what changes we want to make this year. Otherwise, even budgeting 30% still puts the onus on the staff to cover that increase too. So I think it's a real conversation. But you know, I think my recommendation would be separating the groups, at least puts us in the right step moving forward to try to take some of that, I guess, weight off our staff moving forward. So that's all I've got tonight, and kind of open it up for questions or discussion.
Questions from the board?
Just a 1 year
1 year.
contract.
Yeah, no rate guarantee for next year.
I can speak to that. So that was part of our attempt to negotiate as aggressively as we could. And at this point, it's a no on a second year. It's not to say it's completely off the table, but I would assume no. If your loss ratio, and I only say that because if, for instance, West Dallas shows commitment to partnership, like we're gonna move down the ACO path, we believe that's the best way for us to improve our outcomes with our members, drive costs down. Your loss ratio trends better, United Healthcare might come back and reconsider that. But as of now, it's a no-go. Yeah.
So let me repeat that back. What I heard was if we chose an ACO and split out pre-65 from active employees, maybe United Healthcare would consider giving us a rate cap for next year, or next year they might consider us giving 2 years.
So there are a couple of things, so. Don't factor in the splitting out the active versus retirees. Really, the focus right now with United Healthcare is when they're looking at your loss ratio. Right now, you're not running well, you're going for a 56, they're giving you a 30. And so they're concerned about improving utilization. From their perspective, the best way for the district to improve utilization is to implement the ACO. Right, accountable care organizations, you already have substantial utilization going through there. If you continue that under this heightened arrangement, then not only will you improve outcomes short term, but that should drive longer term improvement as well. That to them is a commitment to partnership and trying to improve ultimately outcomes. They may begin to consider a second year more further at that point or further at that point. If also your loss ratio improves this year. So those are the two biggest factors from my perspective. I'd say actually number one is, does your loss ratio improve as the year moves on? There might be an option for a year or two. But as of now, no, I've talked to UHC extensively about that. Does that help?
Other questions or thoughts? Conversation?
So one of the things that we have to give some direction on is the split. Do we want to split out 365s from actives as far as two different insured groups, essentially? To provide savings to the majority of all of our current employees over what, if we kept them together, was obviously increased costs for at least some of the 365 individuals. So that's the first thing I think that we should talk about. Kristen?
My concern that I believe I brought up in committee as well was, these are people who dedicated their time to be in our school districts, and you always feel like, people should have the chance, like $500 a month for a family is a lot. And I want anyone who's listening to this understand that, we do have to think about the future of our district when it comes to saving. Nothing's getting cheaper. And like the future of our new teachers and all that kind of stuff. I don't know, I'm rambling, but I don't know. I understand the presentation and the recommendation and all that kind of stuff, but as a teacher at my heart, it's really hard to also say, okay, now it's $200 more for you this month because we're thinking of the future and it's not you. And that's kind of how I've been feeling about it a little bit. So I'm not against it. I just have to put out that worry out there.
That's certainly tough. I agree, Kristen.
Other thoughts? About that in particular, because I really think that, is the thing that we need to have some direction on about that. Because it makes a big difference as far as, it's 2% roughly difference for active and 20 some difference for not. It's a smaller group of people, obviously, and we saw the numbers about how that all splits out. And how long people would have to deal with that who are pre-65 currently. But I think that, at the end of the day, we have to look at, okay, if we don't do it today, are we going to have to do it a year from now? And is it going to be worse for the outcome? Or if we do it today and get the loss ratios down, would that then provide the onus for our insurance to be a lower rate, maybe get rate caps for 2 years or something like that down the road? So that's really we have to weigh. We don't know because we don't know what the future is going to hold. But will keeping them together do us more harm or good?
Yeah, because I think the reality is if nothing changes next August, it's gonna be 30-40% again, and there's not an ACO version 2. So, it's just like trying to figure out how do you manage that, you know what I mean, next year. And I think that's the concern on my end about, these are tough decisions, I understand, but that's where my head goes. It's not like now, it's next year. If the ACO didn't exist, we'd be discussing the 30%, how do you make it work? That'd be the only discussion we could have.
What do we budget?
We budgeted 20,
So we'd still have to find 10% additional from the budget to do 30%.
on top of the staff, yeah.
She was first stage.
I was just in terms of you want feedback, I was thinking the same thing, that Ms. Kaiser was saying. But my husband works in this field and it doesn't look good. I mean, my biggest concern is if we move forward and we don't separate them out, that we are going to be looking at it unless we do something major to really, and I don't even know how we could, I mean, I'm interested to find out what do you guys recommend for bringing down the high utilization so that we have an option, but just looking at like what we are, I don't want us to end up being backed in a corner by UHC or any other organization and saying, well, this is basically what you have to take because this is all that's available to you. So, I mean, I've kind of felt the same way, like I would feel badly. I mean, less people are impacted, but I think in the overall, I would be in support of separating them out, to benefit our current employees. And hopefully kind of maybe bring that number down so we can be in a spot where maybe we can negotiate or at least bring our percentage down, you know, it's something reasonable.
Ms. Carr?
I'm on the committee, so I've heard this several times and I've had some time to digest. And when it really comes down to it, I always ask myself, you know, what is the job of a board member? And the job of a board member is to make the best decisions financially for the majority of people. And so I always go to that. So I tend to take out pulling at my heartstrings and I tend to say what is good for our district. And so that's why I would be in support of this.
Skyler?
On slide 6, it says like our high cost claimants for year to date were just 13 people. Do we know if they're part of the pre-65 group or active?
I believe so, but I'd have to pull that.
I just think it's important.
Yeah, we can follow up with that.
Okay, thank you. I'm with Ms. Carr as well, but like as a board member, you make the hard decisions, what's gonna be best for our financial future, because right now it's very hard out here for public schools.
And the other thing I think about too is what we're trying to do to retain staff. If we can reduce that cost by the 2% for the staff that we have, I mean, that would be another carrot to keep them. In that difference. That we're really trying to do everything we can to support all staff. But the boots on the ground right now and the students that they're serving are the ones that I have the most concern for. We want to see improvement in scores as well, but we can't do that if there's not a staff member there to assist.
If I could just add additional color while you contemplate maybe additional questions or discussion. You know, it's to not just looking at United Healthcare itself, but think about that slide where we talked about the market and the absolute lack of appetite for the risk on the health plan. So that tells me something needs to be done to increase options, but really Anthem, United Healthcare, those are the giants, right? Anthem's out, United Healthcare, you're looking at what you're looking at. So that tells me really need to take some steps. In my opinion, moving to the ACO is one of the best, least disruptive steps you can take to really drive that utilization down longer term and again, manage costs while continuing to provide great benefits for your employees. I really like the ACO strategy. And that's why you're seeing a number of other, not only districts, but private sector groups move down that path as well.
I was gonna say just for industry background too, I work in the Medicare space and there's a lot of headwinds there. So I think part of that appetite is about companies just trying to save their bottom line because of Medicare. They're just getting crushed right now. So that's just unfortunately, it's a tough pill to swallow. But I just don't know if it's gonna get any better anytime soon.
Looks like there's much relief inside, right? Don't hear great news about it.
And that's the other point that I think is important to consider in this is that self-funding, which would probably be the most cost-effective thing for everyone, employees, district, is going to be much easier to do if we do have that split out. The cost required to do that is going to be less if we're looking at active employees versus everybody who's not 65. So that's the other thing that basically what we've been being told anyways is that's probably where we're gonna end up in order to be able to have a viable long-term financial ability to provide insurance for our employees. And short of, universal healthcare coming from the federal government, that's the only other option that I think that we're gonna end up being, which is doing it ourselves. But right now, it's just too expensive the way we have it. And I don't think we have until 2037, when all the pre-65s would be 65 to get that done. I don't think we're gonna have enough money to do that. At least I'm gonna presume that's gonna be the case based on history. Any further thoughts about this? So we need some direction. So the first direction I'm gonna ask about is moving from what our current is to an ACO. So thumbs up, thumbs down, just moving from where we currently are to an ACO. Everyone thumbs up, Jeff's. Okay, all right. So then the second question is ACO, everyone together at 9.4% increase, or splitting out our actives from our pre-65s. So if we are in favor of splitting out actives from pre-65s, your thumbs up. If you're not, your thumbs down. Additional direction?
I think that's it. Just looking for, I can talk with Terrence about when to bring it, but we're thinking in September. So either the next meeting, depending on the agenda, or the following.
Can you give the results?
Oh, I'm sorry. It was every,
All people on.
yep, it was all thumbs up.
Okay,
Yeah,
thank you.
for the second question.
Yeah.
The first question is all thumbs up except for yourself, Mr. Sickich. All right.
Okay.
Okay,
I think we're good. Yeah.
so this is complex. This is not easy. But, for our board, I think we've got used to doing things that aren't easy. But I think, again, long-term viability, the best for the most, as we try to do, as Ms. Carr eloquently put before, that's what we have to do. And it's not easy for us to do that. We understand this is going to be hard for some people with what we end up with. But for the long-term viability of our district financially, I think this is probably the best route for us to go. So thank you for entertaining this and thinking about it. Thank you, Dr. Brown, Mr. Norris, for all of your work and putting this together, because I know it's complex. I thank you for the committee for going through this process and getting it to a point where we can, as a whole board, think about it. So if there's anything else, if there's any changes or anything that, let us know, or anything else that comes through. Otherwise, if there's no other questions or comments, I would look for a motion to adjourn.
To adjourn.
Moved and seconded. All those in favor?
Aye.
Opposed? We are adjourned. Thank you much, everyone.